So, welcome to another concept. In this classroom, we discuss safety, and we said that safety is core. And the purpose of covering this concept is to give you the core knowledge you need to understand and practice the patient care using the patient safety principles we're going to discuss here. And in the end goal is to be competent to maintain a safe and effective care environment for all patients. And so you see this concept is going to be repeatedly covered in all courses and at all specialty levels in your journey in the nursing school. So you have the module learning outcomes, and you have here in this specific lecture these learning outcomes. At the end of the day, you need to understand the scope of the problem of any unsafe practices that you engage in, and you should be able to understand, compare and contrast, like how we as healthcare providers view safety and harm, and how the patient's experience is going to be. And because at the end of the day, it's them that they're impacted by those ill effect of our care. And so how did that historically develop? How did the safety movement start? Why do we need to integrate the concepts of patient safety in every action we do at the bedside? And what are some of the terminology, vocabulary that is engaged and involved in this concept? What are some of the agencies that govern and make sure that we are all practicing as prudent healthcare providers? So before we go into the book's definition of safety, or rather what the book reported as the definition of safety, I would like to tell you that, that safe patient handling or care is really doing the right thing and doing the right thing well. So these are the definitions that are in your book. And now if you go to Giddens, the first page in that chapter, I think page 423, 428, I mean, is going to be the page where you see all these different definitions. And there are different definitions because the safety, patient safety movement started with that report from the Institute of Medicine, and the report that was published in 2000, and the name was "To Err is Human, Building a Safer Health System." And in that report, they described the risks of medical care in the United States and the documented harm that has occurred because of unsafe practices within the healthcare system. And they talk about the estimation that up to 98,000 patients die within the hospital due to medical errors yearly. And they went into details about the unfortunate and events that are adverse events, we can say. And they talk about how these are preventable, and that's why we cover this in this course, because we want to prevent them. And at least 50% of those events reportedly in different literature in the evidence-based talk about this. So that's where evidence-based come from. That's what the Institute of Medicine got that data from. And so they reported what does a safe care mean, what does safety mean. And then that definition may have been expanded in some places, narrowed. At the end of the day, what are we trying to achieve when we are doing the right thing? Well, is we are trying to ensure that the safety of the patient to whom we're providing service is maintained, and that is of essence in our practice. And I want to highlight that the issue of medical errors or adverse events due to unsafe care is not an issue in the United States only. It is a global problem, and actually those adverse events are one of the 10 leading causes of death and disability in the world, and it's obviously maybe we can't state whether it's worse in developed countries as opposed to underdeveloping countries, because one of the things that's going to be essential here is are the errors being reported as such. And so um, I'm saying errors, and I'm not putting blame, and I'm not saying, and neither any of the patient safety bodies that you're reading about would say that it is something to blame. It's an error because to err is human. What we can do is um, um, try whatever is in our potential to prevent it. And if we can't prevent it, at least minimize the potential harm from it. And then you see there are multiple entities that work on this. WHO works on that. The National Patient Safety Foundation works on that. The Patient Safety Network works on that. The Agency for Healthcare Research and Quality works on that. So there are multiple venues, and you see in nursing, there's this Robert Wood Johnson Foundation. They did a national initiative, and within the Quality and Safety Education for Nurses, the QSIN, built upon the Institute of Medicine report, and talked also about the definition of error, and basically what they said is that safety is minimizing risk of harm to patients and providers through both system effectiveness and individual performance. And so we are, as nurses, held to that level. We have our own take on patient safety. So then we go on to another layer of definitions, and that's what is an adverse event, what is a near miss, what is a sentinel event. And so adverse event is anything that is, even in medications you learn that it's the unintended outcome that you wanted. And obviously we never go to work deciding that we want to harm somebody. We all go to work and get dressed up to do a good job, and that's why unintended is there. It's an intentional word, that harm was unintended, and it was like either a commission or omission of whatever duty we had. And so an adverse event is an event that happened, and a near miss is an event that did not happen. It was gonna happen, but something prevented it. Let's say somebody caught that error before reaching the patient, and so that's why it's a near miss. Sentinel event is an event, the adverse event that caused a serious injury up to death. So anytime we have a serious injury, it's called a sentinel event. We'll talk about these levels of errors and this activity in class. So how do they categorize errors? And there is a scope, in between keeping patients safe to, oh, we caught it before it happened, and that's where near miss, to the error reached the patient and it either caused injury, whether it's minor or major injury, or it led to disability, or it led to death, and sometimes it just led to an extended length of stay for that patient. So when you look in your book, and on page 429, they talk about these types of errors, diagnostic errors, and these are errors due to either wrong diagnosis, delay in diagnosis, not doing the right test to diagnose, using tests that are inappropriate or outdated, versus when we say a treatment error, it's when we're doing an operation, a procedure, a test, a medication, we're administering that treatment to the patient and we fail. So even if we right or wrong treatment, it would be considered a treatment error. Preventive error, remember we talked about primary prevention, and that is going to sit in that category. Preventive error is whenever we fail to do the prophylactic treatment, the prophylactic monitoring to prevent any event of happening. Sometimes it's at the primary prevention, sometimes it's at the secondary prevention, like we're not screening enough, or sometimes it's at the tertiary prevention, we're not preventing the wound from becoming infected. And then a major category of errors is some books will refer to it as miscellaneous because it may be communication, it may be system, like where there is no guidelines within the institution to how you should position the patient or how often you should do that. But the main in that category, so anything that's not diagnostic, not treatment, not preventative, is going to be in its that category of communication, meaning that there was a lack of communication or communication was not clear enough, and it was the reason why the error happened. Then you see the talk about the latent versus active scope of error. So latent means it's something that is hidden or lying inactive within the healthcare system. For example, a flaw in the system that doesn't immediately lead to an accident, but it directly led or triggered the event and led to the error. And for example, your book talks about the nurse who administers the incorrect medication because she failed to check the medication error, and that is an active error versus the latent, where a medication that looks like another medication is stuck in a nearby, and so they're both put in the same in the near vicinity of each other, and then you're grabbing one, and because they look alike, you grab the other one. That is latent because it's an accident waiting to happen, and that's how they differentiate between the two. Okay, again, we'll discuss these types of healthcare errors in classroom. So what is the culture of safety that they're talking about? So to err is human. That was one thing that never was really highlighted before. It was the culture of shame and blame. If you did an error, you were fired. And really, the systems had to go into their system, like how the process is, what do they have in place to help you as a human that will err not to err. So how do you forcefully make everybody do the right thing from the beginning? So this is where the culture of safety came about, and at the core of organizational culture of safety comes human factors, and we'll talk about this in a second. And so the cues and attributes of safety, we talked about the cues and how they're involved. So you have the knowledge, and so Cuson says that we as nurses, we need to be knowledgeable, and to make the distinction between unsafe practices such as workarounds. Okay, and workarounds means like if there is a fail safe, and fail safe is something you put in place to prevent somebody from doing the wrong thing, encourage them or force them to do the right thing. So that's where, like, they put every medication in a different drawer, and you have to key in the Pyxis system, where you're gonna get your medications from when you're administering medication in the hospital. You have to key in the patient's name and you sign in and whatnot. And then if you wanna get it, and if you're in a hurry, you have to bypass the system. So that's workaround, is bypassing something in as a fail-safe, and that's on the knowledge level. To at least know what are what are you meant to do when there is um, a potential for error. And so when we talk about the skills, first, do you know how to do the even if it's like the skill that you're performing, even if it's within your scope of practice, do you know how to do it? Are you trained to perform it? So um, these are some of the elements that we think about when we have the skills. And attitude, it's always, doing things in an evidence-based manner, doing things knowing whether it is within our scope, within our limitation of human performance. Like we should be able to acknowledge, and acknowledging something and adopting it as our behavior is what attitudes is all about. So when we talk about human factors, what they're talking about here is that we know that to err is human. So what do? You factor in the fact that humans are going to err within building the procedure, how we're going to do things. Okay, we're going to do things, but we know that people might be tired. We know that people might be on autopilot. And they're not focusing. We know that people might be in an emergency situation. So if somebody is in an emergency situation, how we can build how they're going to access the medication cabinet without them making an error, which is built in the fact that we are human. That's how they do the human factory. So your book on page 430 talks about this study by Ebright, and they talk about patterns where human factors and the job we do as nurses within the acute care environment work to um, like make things maybe go in the wrong direction. So they talk about disjointed supply resources, missing or non-functioning supplies and equipments, and these two are talking about just merely what the system supply you with. For example, if you're used to certain Foley catheters and whatever that kit has, and now they change the supplier, now it's a new system, and now you're gonna have to learn it before you do it. But what if you're doing it in an emergency and you don't have time to uh, do it? And then, the interruptions, when they talk about interruptions. So what do they mean by interruptions? It's like I'm passing meds and I get interrupted by a phone call or a colleague that's talking to me. What is going to happen is I'm going to lose focus and I may pick the wrong medication or wrong dose or whatnot. And then they talk also about the breakdown in communication and communication media. So these 8 elements are something that you need to be familiar with so that you can understand when you're performing, when you're the human there, what factors are impacting and how can you be part of solving that problem. Then the next element is the crew resource management. And the crew resource management is something that the aviation industry, so pilots go through, where everything they do is standardized. So there is no surprises. So the checklist, you know that checklist, you know that it has 10 elements and you have to check every element on the checklist and you have to really check that you got it right. So that's standardizing the procedures, standardizing the communication is gonna reduce errors and thus reduce the patient harm, and it's going to increase your efficiency because once you have a checklist, you don't have to sit there and try to remember, oh, did I do it? Did I not do it? Was I supposed to do this or that? And that's how that was one thing that was adopted along the journey of patient safety movement. Like they started small and now they're going big and making sure everybody is trained to be well acquainted with crew resource management tools. And they have tons of tools. And one of the main focus in Crow resource management is that teamwork, and especially in somewhere where like you're in the operating room, and teams have to all be responsible to make sure that the patient is safe. It's not a one-man show. It's a teamwork. Then they talk about high reliability, oh, it's a mouthful, high reliability organization, HROs. And these are organizations that are proactive rather than reactive. So they think about what could go wrong and put um, uh, processes in place, uh, put the right mechanism, the right guidelines, the right checklist in place to prevent it from happening. So what could go wrong in a surgery? Okay, we might forget to check whether the patient surgery is going to be done on his right knee or his left knee, or whether we're doing mastectomy for the right breast or for the left breast. So they'll say, okay, we institute timeout. And what timeout is, everybody stops in the OR right before they're starting the surgery and say, okay, time out team, what's the name of the patient, what procedure we're doing, and then they all are on the same page, making sure that the error is not going to happen. This is what high reliability means. And I can never stress enough the role of the nurses and nurses' vigilance at the bedside, and how it ties to their ability to ensure patient safety. And so you'll see that be faced with nursing staffing issues and unsafe practices where you're assigned too many patients, or your patient's acuity and how sick they are is not proportional to how much time can you allocate to that patient. And even if you did have the correct staffing, is your skill mix and training appropriate for the procedures and patient care that you are doing? And so when we go to evidence-based and you look into literature, you're going to see that, your nurse to patient ratio is one of the key element of how, increased patient turnout was associated with increased mortality. And when you see that when nurses are highly educated, and so you see that bachelor, BSM prepared are um, and those institutions that have more BSM prepared nurses, for example, mortality rate drops in surgical patients, and these are facts. But we want to talk also about working conditions, and so healthy work environments. And if you're bullied by your colleagues or bullied by the provider, how's that going to affect the patient care? And going back to those skills and knowledge, skills, and attitudes, those cues and attributes. So then is what makes a just culture? That really feeds into okay, if you avail for me all these working conditions and staffing level that will make the work good for me, or work for me, so I can do my job right and do it well from the first time. You'll see that that's what defines a high reliability organization. That's what defines a patient safety culture within the organization. And one of these themes is the just culture. And so in a just culture, you see that you're able to report an error and not feel that you're going to be shamed and blamed. Rather, they're going to work on you to improve what deficiencies, whether you were trained to do this job. And so the way they address errors in a just culture is what makes it a just culture. So, but here you have to understand that they do differentiate between was that a human error? Was it at-risk behavior? Was it reckless behavior? And so what do you what was the performance behind the error is what is going to justify the consequences. So in a just culture where there is no shame and blame, there are still accountability and liability for what we're doing. We're going to cover the ethical, legal aspect in a few weeks. And so transparency is us being able to report those errors. Of course, if we're living in a just culture, we're going to be able to do that. We're not afraid of repercussions of reporting. But most importantly, transparency is when we report to the patient. When we come to the patient and we have that open communication before even the patient knows, or even if the patient is not going to know that there was an error, we come forward and be transparent. Okay, this is what happened. And studies, evidence-based, have showed that people are most welcoming for a forthcoming attitude when you come forward and say, I made an error, but this is how I'm trying to fix it, and this is the action plan so that same error doesn't happen with any other patient. And so we'll talk about this. If you have any examples to share, you'll share it with me, with that group, I mean. And obviously, healthcare quality and safety are two faces of the same coin. Communication, we talked about communication and how many errors are embedded with that lack of communication or miscommunication. And collaboration, it's a teamwork, and the patient is at the center of that collaboration. And care coordination more is seen more, in the continuity of care. So continuity of care in the same hospital when the patients move from the ICU to the step down to the regular floor, or continuity of care from the outpatient to the inpatient to the rehabilitation to the home care, or continuity of care between the primary care physician and the hospital. So that is care coordination that need to happen, and systems and documentation need to be shared so you know what the patient is taking when they go to the primary care physician, whether that drug was stopped or not. And finally, the features examples. Of course, we started the talk about fall prevention. We're going to continue with medication administration. That's the module you're completing and doing the exam about this week. It's safe medication administration. Obviously, the game is in the name. And then we're going to cover seizure precautions. We're going to talk restraints and restraint use. We're going to talk about fire safety. So we'll talk about some of those precautions that are mandated by those governing bodies that are in that are there to ensure that we're maintaining patient safety. It's kind of like police for patient safety. Although we came into this profession because we wanted to do good, and so we don't need that police. It's just, check and balance. And then so we'll continue this conversation in next presentation. Thank you for your attention.